patients go to coronary bypass graft surgery, we are often perplexed as to what to do if they need continued antiplatelet therapy because of bleeding complications. We know that bleeding is not good for patients, but patients that bleed because of antiplatelet therapy have been shown in the Triton and Plato studies to have less mortality post-op. Now in JACC, patients undergoing off-pump CABG surgery were studied to see if platelet inhibition studies could guide which patients would bleed. Not surprisingly, a high percentage of platelet inhibitory response to Clopidogrel, regardless of the proximity of Clopidogrel exposure, predicts increased blood loss and transfusion requirement after CABG, with a cutoff value of 70% for an increased risk of transfusion. So what does this mean for our patients going to CABG surgery? Well, these findings might implicate a potential role of platelet inhibitory testing in deciding the timage of OpCab in patients needing continued clopidogrel therapy. What this study does not say is even more important than what it does say, and it raises a number of questions that need answers. Are platelet inhibitory studies the best tool to identify potential bleeders during or after surgery? Is the cutoff value of 70% obtained with a TEG platelet mapping assay the best threshold for the risk of bleeding? Is this value the same for on-pump versus off-pump surgery? Can we improve the prognosis of CABG patients by systematic monitoring of platelet function and operate when they reach a predetermined window of platelet activity? Well, all of these are questions. Lots of them remain, but this study is provocative and hopefully will stimulate even more definitive studies. I'm Peter Block with the CardioSource Heart Minute.